Well, basically, there is a lot of evidence of the usefulness of caring for iron deficiency, but it's always a good thing to review what we know and look for the new things that have come out. As I told you yesterday, I believe that the caring of patients according to comorbidities is our way to have precision medicine made available to the patients. These are problems that require solutions. Iron deficiency with and without anemia is one of these things, and we have a number of trials now ongoing trying to also establish whether morbidity, mortality will be lowered when you are caring for iron deficiency. Now, talking about the subject, I really always start with the definition because there is conflicting kind of thinking about this. And this comes because the thresholds for healthy people assessing iron deficiency, which in that case then is absolute iron deficiency, are different than the thresholds used for chronically ill patients, where we want to really assess functional iron deficiency. A ferritin less than 30 is indicating absolute iron deficiency in anybody. And whenever you see that, you should think about bleeding, you should think about cancer, particularly when accompanied also by weight loss. You need to exclude this before you then continue further. However, most of your patients in heart failure, and this is a heart failure symposium, really will not have such low levels of ferritin. They will have levels between 40 and 100 in almost half of the cases of all heart failure patients that you see that are symptomatic. Now, in those patients, ferritin less than 100 and the ferritin between 100 and 300 with a transferrin saturation less than 20% is indicative of having iron deficiency. And you can already see that I didn't mention so far any hemoglobin levels. This is because iron deficiency is a definition, is a diagnosis made without even looking at the hemoglobin. Looking at the hemoglobin, still, you can then distinguish patients with and without anemia. And what I would like to show you is that having anemia and iron deficiency is not one problem, but is two problems. Patients with heart failure, 50–60% when they have anemia have iron deficiency. Patients with heart failure without anemia, about 40%. And iron deficiency is prognostic independently of many other important factors of the life of heart failure patients. But take away iron deficiency is frequent and iron deficiency is prognostic. Now, we should ask ourselves why in certain countries and Arab countries, but then also in India and China and Japan, you have very high frequency of the occurrence of iron deficiency. And one of the interesting issues is that iron deficiency is in part caused by tea drinking. When you drink tea with a meal, you're chelating the iron in the meal. So 1 cup of black tea basically abolishes the value of the food for 80% of its iron. You might say, what about green tea? What about other types of tea? Well, they have about half the chelating capacity, so they are better. But very often when you drink, let's say jasmine tea or something, you drink more than 1 cup and then it becomes the same kind of problem. How can you avoid this problem? Well, if you have a 1-hour break between food intake and tea drinking, then this problem is basically gone. Are there any substances you can take in to promote even the uptake of iron from the food through the gut system? Yes, vitamin C containing fluids are an option. Vitamin C is promoting the uptake of iron, and so orange juice would be basically there of benefit. The second thing is, of course, vegetarian food intake. Now, vegetarian food does not contain less iron, but different iron. And there are 2 pathways making it into the body with the iron. and one is related to heme iron, coming from meat, and one is related to non-heme iron. And the non-heme iron pathway, which is of course relevant for anybody who's vegetarian, is 3 times less efficient for uptake of iron. We are basically genetically developed into carnivores, and we have optimized the iron uptake that of course is needed for metabolism through meats, and vegetarian food intake may be en vogue, but it has also its disadvantages from these kind of aspects. And lastly, of course, but this is then true for anybody, heart failure patients have tissue inflammation, and with tissue inflammation you have activation of a system that causes iron deficiency. Inflammation triggers the production, amongst many things, of hepcidin. Hepcidin is basically invented by nature to reduce available iron in the context of an infection. Nature didn't think about heart failure. Nature only concerned about reproduction. And when most people died of infection about, we're talking now 1 million years ago or longer, then basically doing this was very logical for nature. Bacteria thrive on iron. Inflammation is basically, as a natural response system for the body, something like an infection, even if there is no infection, because we have in heart failure a chronic tissue inflammation, but the response is wrong. Hepcidin is produced, ferroportin interacts with hepcidin, and then in macrophages and in gut cells you have a trapping of the iron, and therefore it becomes unavailable for the rest of the body, and that is the core of functional iron deficiency. Having said all that, the important thing is management, and the focus here is iron. Blood transfusions are really not an option. EPO really is not an option. It's a class 3 recommendation because there is no benefit in heart failure patients symptomatically or prognostically. It costs just a lot of money. Iron is what we want to use, and iron on average is given as an intravenous iron, depicted here symbolically, or oral iron, and I will discuss oral iron in a second. Intravenous iron always means it's a sugar shell and carrying some iron, and then the different compositions matter because that determines whether you can give more like 60 milligram, 200 milligram, or even 500 to 1000 milligram in a short infusion. The anaphylactic reactions you may have heard about come from dextran sugars. So really the recommendation is avoid dextran irons, and then you don't have anaphylactic problems. Old data, but still interesting data, the Phage F1 trial. We did this now 10 years ago to this time, and we had a strong improvement in symptoms and exercise capacity. 2 primary endpoints were patient global assessment of well-being and New York Heart Class. This being a double-blind study, quality of life and performance can be at the core of things. And maybe making one small comment on the discussions yesterday about MitraClip. Don't forget, MitraClip is given in open label scenarios. Quality of life and exercise capacity assessments in the context of an open, very invasive and expensive procedure are totally biased. Anybody will say it's a good thing that you spend $30,000 on me, and so this should be really ignored. What is key is the prognostic data, and there we should have the debate. Now, here with intravenous iron and double-blind studies, convincing improvements. They are actually very fast. In this study, the first assessment was after 4 weeks, but we are now seeing the improvements in symptoms and quality of life after 1 to 2 weeks. If you give intravenous iron to your iron-deficient heart failure patient, that is almost like a good physician-patient relationship enhancement program, because the patient will feel a difference fairly quickly, and that is good for the long-lasting good quality of that relationship. Now, why did we actually get this study accepted in the New England Journal? And this coming slide is the reason. Because we prospectively basically organized the study in a way by stratification that patients with and without anemia basically were included in the trial, and we are able to make valid assessments of the impact of treatment in the subgroups of patients with and without hemoglobin below 12. Now, basically, when you look at the patients in the top part of this numbers section, patients with anemia, in red you can see that they had a hemoglobin improvement of about 1 gram per deciliter. Not a lot, but okay, it was there. But then the important part is the patients without anemia. In the bottom line, there was no difference whatsoever in the hemoglobin, so you don't need a change of hemoglobin to still get the same benefit in the non-anemic patients as in the anemic patients. Hemoglobin changes are not the mode of action for the iron. And you see, this is a falsification. We can exclude iron as the mode of action. We still very often ask ourselves, how does the iron then work? Well, and basically, we think that iron is important for hemoglobin production, of course, and oxygen carrying, but that's not the leading problem. The leading problem is the energy production side, and we know that iron is relevant for the respiratory chain system and for the energy production in mitochondria, and every cell needs energy to function well, and this is how iron probably works, but as I said before, mechanisms are sometimes difficult to positively prove. The good news is kidney function is also improved, and there are not many things that actively improve kidney function, and Tresto may be another one. Exercise capacity, and in Confirm-HF we tried to confirm exactly that point. 6-minute walk test does improve in patients with heart failure and iron deficiency if you correct the iron deficiency. 33 meters on average, which is a clinically relevant change. Now, in the Confirm-HF trial, we had for the first time then also prospectively an assessment of events for efficacy. Secondary endpoint, hospitalizations with heart failure, significantly reduced, but the numbers are small, 10 versus 32 events. This is not something where you can base long-term decisions on, but it is a good hint in the right direction. This is the Kaplan-Meier curve, very early separation being significant. Now we extended the evidence then into a meta-analytical approach of all 839 patients having received intravenous iron or placebo in randomized trials. And here you see a time to first event analysis. Anything that is in blue is significant. That's good news. But even more good news if you do this with recurrent event analysis, where each patient can contribute with several events, and all these different typical cardiovascular mortality, heart failure or cardiovascular hospitalization combinations, they all tell you more than 40% benefit. If this holds true even halfway in the big trials, we are in for another very positive comorbidity-based therapy. So the current recommendation is to use this in iron-deficient patients to improve symptoms and quality of life. The future is that there is trials ongoing. Ironman is testing isomaltose. HeartFit is testing in the United States with a different dosing because the US hasn't approved the 1,000 milligram dosing. They're using the 750 milligram dosing. They're doing a 3,000 patient study, time to first event. And I could tell you now that Affirm-HF in the summer of this year has finished the recruitment. In the end, almost 1,300 patients. And by the end of next year at the AHA, probably, we will see the results of this 1-year follow-up study. A 1-year follow-up of 1,300 patients is not bad, but this study will be 2 to 3 times bigger because the follow-up will be 2 to 3 years of the same number of patients. Phage F2, we are running this and in Germany mostly, but now trying to extend this internationally and hope to have in 2 to 3 years also for this longer follow-up than the numbers of the benefit. When we designed these studies, we were asked about oral iron as a comparator, and luckily then came out the iron out study, and oral iron simply doesn't work. Now here is 225 patients randomized to oral iron versus placebo. This is the primary endpoint for exercise capacity, exactly nothing. Here is the secondary endpoints with kidney function, quality of life, basically looking at BNP levels, looking at the respiratory efficiency, nothing. Nothing worked when you gave oral iron, and the reason is that the oral iron, basically giving it to patients with heart failure, didn't correct the iron deficiency. There is in patients with heart failure at least now evidence that there is a blockage of the uptake, and it just doesn't get into the body, and what doesn't get into the body doesn't work. Whereas with intravenous iron, you have no avoidance. You give the iron, you know it's in the vein, you know there is basically therapeutic efficacy to follow because you have the iron in the system. What else is new? Well, just recently there was in the Lancet a publication that intravenous iron, EPO, vitamin B12 and folic acid together as a multi-therapy kind of approach in the surgical context. This cocktail avoids one blood transfusion unit. The only problem is the cost of the therapy is equal to the cost of the blood transfusion unit that you're saving. So definitely not a cost-effective kind of approach. If you do not want to get blood products for whatever reasons, then it may be an option, but otherwise not a dramatically good one. And always, and this is more a question coming from the hemodialysis field, there was the question, is it actually harmful or beneficial to give more iron rather than less iron? And using iron sucrose and high dose strategy, aiming for about 400 milligram per month unless you had a very high ferritin level to stop you, and alternatively a more reactive low dose kind of therapy that basically wanted to prevent ferritin going below 200 or TSAT below 20%. So a reactive low dose kind of response system, or a high dose continued 400 milligram per month approach, and to analyze whether MACE events could be reduced. Well, and the fascinating thing is you can reduce, tested here in 2,000 subjects, you can reduce MACE events with this approach, significantly so. And the nice thing, and then the surprising thing, is particularly the infarct section. 31% reduction of infarcts, 34% reduction of hospitalization with heart failure. But heart failure hospitalization in these patients are relatively rare. But infarcts, that's quite interesting. And so maybe in the future we will do something more on the infarct side as well. So iron deficiency in infarct patient, if you look for it, you will find it's very frequent. Let me finish. We have here an interesting therapy that makes patients feel better and perform better, whether or not treating iron deficiency with and without anemia also will improve prognosis. We shall see in the near future. What we can say for patients with heart failure, that it is already in the guidelines for this symptomatic shorter term therapy, that we think it works through mitochondrial energy kind of improvement, but the long-term results are to come, and so let's look out for this. Thank you so much.